Hi, everyone. Thanks for joining tonight. Michigan Center for Regenerative Medicine, Dr. Tom Nabedy.
Dr. John Santayana. Thanks for joining us tonight on this webinar. We have a couple of exciting things to talk about. First of all, Dr. Farhat and Dr. Nabedy just returned from one of the premier conferences in orthobiologics and regenerative medicine every year. This one's from Scottsdale, Arizona. It's the Interventional Orthobiologics Foundation. They just came back from that conference, and they came back with a lot of really cool information to share for us today.
Yeah, so we went down to Scottsdale. It was a 2-day conference, met with colleagues of ours from around the country. We're recognized as being one of the leaders in the country based on our outcomes and the tracking patient registry we use called Data Biologics, which was very rewarding for us. As a clinic, reiterated that what we've been focusing on are updating our clinic and improving our clinic, all focusing on getting the best possible outcomes for our patients. Being recognized on a national level was really great. And then hearing the lectures and hearing what these best practices are that are evolving from other clinics and other clinics who are getting great outcomes, and having it echo with what we're already doing here at Michigan Center for Regenerative Medicine was really rewarding and a moment of pride, I think, for all of us.
Yeah, I agree. So I think the biggest thing that was touched upon was something we tout ourselves every day is we're looking at a dosing. So when we're doing our procedures, we quantify what is it that we're actually injecting and cell count that we're using. And that was reiterated multiple times. And we're starting to get to a point where the societies are starting to recommend dosing for specific body areas, which we've been doing for years now, and we easily meet the criterion that they're recommending. And this is across the board for all body areas, especially shoulders and knees. So it's extremely exciting, and it sort of reaffirms that what we're doing is appropriate and what's best for our patients.
So it sounds like everyone else is catching up to what we're doing, so it's good. From that conference, what do you guys see like a different, what do you call this, like a demographic of providers and physicians?
For sure, yeah. So there's it's not just interventional orthopedic physicians like ourselves, interventional pain physicians like ourselves. The society is now starting to incorporate lots of other different medical specialties, and probably the biggest one that's you can see starting to come involved is the surgery groups. So the orthopedic surgery and orthopedic surgeons are starting to. They're still not outnumbered by the interventional pain docs, but the numbers are clearly rising.
Oh yeah, we're talking to some of these major orthopedic surgeons that are known for specific sports type injuries all across the country that are really utilizing orthobiologics as a treatment instead of taking patients to the operating room, which is extremely exciting. And actually, one of the things we're going to talk about tonight is the shoulder. So one of the forefathers of our specialty, Don Buford, who's an orthopedist, sports medicine orthopedist out of Texas, who specifically treats shoulders and knees, presented some interesting data that he's been collecting over the years, which is extremely exciting and reinforces, again, what we're doing. So that's what we're going to talk about today.
So it's a really nice transition to our topic today. Today we're going to be talking about orthobiologic treatments for the shoulder.
So just a real quick anatomy lesson. So I'm not sure this is the best model, but you get an idea that this is the shoulder. And one of the most unique things about the shoulder is that it only really has one bony attachment to the rest of the body. The rest of the shoulder is pretty much soft tissue supported, mainly by muscles, and the thing that holds the shoulder in place is something called the labrum. So here's a bony anatomy. This right here is the clavicle, or the collarbone, some people call it. This right here is the upper arm, or the humerus. And this is the scapula. So between these three bones develops the shoulder. And in between these structures are the soft tissue or muscle. So this we all know is the humerus that moves up and down. And then there's four muscles that come off of the scapula and attach out here, which is the rotator cuff. The rotator cuff, people think, is a supporting structure of the shoulder, but it's not. It really, all those muscles do is move your shoulder. The real supporting structure is something called the labrum, which is this cartilaginous structure that extends off of the glenoid. So I refer to this as a golf ball on a plate, right? If there was no soft tissue on here, it's like trying to keep a golf ball on a plate, which everyone can imagine is not very stable. So the only way this stays in place is pretty much the labrum. The rotator cuff is potentially injured with various maneuvers, and over time it can get degenerative and eventually get torn, but people can function with a torn rotator cuff, partially torn especially. Completely torn is a different story. And then we have this joint here, the glenohumeral joint. So the glenoid and the humerus make a joint. That's the ball and socket joint that allows us to do all these incredible movements with the upper extremity. And because of this range of motion we have of the shoulder, also puts it at risk for several types of injuries. So that's kind of the basic anatomy. We also have the biceps tendon, which comes right through this little groove right here, which at the top actually inserts as part of the labrum, and the rotator cuff kind of coalesce at the top of this structure right here. So those are pretty much most of the structures we treat when they're injured, especially with the orthobiologics.
So people come to us with shoulder pain all the time, and by virtue of a history and a physical exam, imaging, a lot of what we'll do in-house with an ultrasound right at the bedside. If an MRI is necessary for some structures, we might order it, or certainly if people have it already, we'll review it. And then stratifying our treatment plan will depend on what the source of the pain is. So maybe if we start with a rotator cuff patient, Dr. Santana, if you wanted to kind of comment, what's your approach to somebody who's got a rotator cuff tear, and how do you go through your mental math of which procedure is best for them?
Yeah, so usually, like you said, so when patients usually come to us, they're already seeing other specialists and the primary care. They're trying the normal course of treatment for rotator cuff or shoulder issues. They've gone to physical therapy. They probably had an injection or two already, and they're here looking for other options aside the surgery. So from an orthobiologic regenerative medicine point of view, there's the first thing that we do is do a really comprehensive physical examination. So like Dr. Farhat mentioned and showed in the anatomy, it's a pretty complicated structure because you're not just dealing with a bone and joint issue. You're dealing with a lot of soft tissue, ligaments and tendons that's affecting the entire structure of the joint. So we look at it really well. We do a physical examination. We do an in-house ultrasound evaluation if you don't have any imaging on MRI to review. And then we try to figure out exactly where the source of the pain is. Now, depending on the severity of the rotator cuff, so it's a lot of times we know from literature and from data that rotator cuff tendons that are partially torn respond really well to biologics. Rotator cuff tendons that are completely torn can still respond, but if it's greater than a centimeter and there's a retraction where there's the two ends of the tear is more than a centimeter apart, then usually the prognosis is not so good. So as long as we kind of keep within those parameters, you educate the patient about kind of what is a good prognosis and what's a good option, then we can come up with a plan. From there, we can decide on whether the biologics such as PRP would be a good option for it. So for like a small tear, partial tears, maybe some mild arthritis, that's always going to be a good option for that. Next best option would be to use stem cells. From that source, we can either use lipoaspirate, which is from fat, or bone marrow stem cells that we get from bone marrow. So both of those two options, the stem cell options, work really well for more advanced type things. So for rotator cuffs, I do like using PRP because it's from a, technical procedural point of view. I find that it's easier to inject, especially for a very target specific tear in that rotator cuff. I think PRP is really good for that. Otherwise, but more often than not, we end up treating multiple structures. So it's not as an easy approach. We just use one tool for one issue.
And rotator cuff's a tendon, so biceps tendonitis commonly coincides with a rotator cuff injury. So the same applications for a rotator cuff tendon also apply for a biceps tendon. So oftentimes those two being treated at the same time with the same product makes it just make a lot of sense for various practical reasons to do both of them with the same PRP at the same time.
Yeah, and the thing is, Dr. Santana was mentioning, so it's the rotator cuff is made up of 4 muscles, but usually more than 50% of the time, the supraspinatus is the tendon that's at risk, and that's the tendon that sort of sits right on top. Right on top here, comes across, and the reason it's most susceptible is just because of a poor mechanical advantage. It is rubbed up against this joint, which over time gets arthritic, and sort of creates a fulcrum. And so at this point, it kind of tears right at where it pinches right underneath that spot. So the thing about the supraspinatus is it's an extremely wide tendon. So it has width and it has depth. And so when we talk about partial tears, it can partially tear with width or depth or both. So it's critical that we identify the tear where it is, and when we do our treatment, we localize it under ultrasound and put the treatment right in that spot. That's kind of what Dr. Buford was talking about. So if we were able to identify these tears with partial tears, which most people, probably 90% of people that we see have a partial tear, it's very unlikely there's a complete tear. Otherwise, your arm wouldn't work very well and you're usually going on an operation. So most people that we see are candidates for these treatments. The document and the data he presented was impressive. So he treated dozens of patients with these partial tears with bone marrow treatment, and they would completely heal, return back to sports, return back to normal activities. And this is the guy that actually does the surgery, and he was saying, hey, do this instead. So it kind of gives you a great idea that this treatment is extremely helpful.
So I guess a transition to the other question, when do you guys decide whether PRP versus bone marrow versus lipoaspirin would be the way to go?
So in the rotator cuff world, if it's a complete tear, certainly if there's small amounts of retraction, I'm going to reach for a stronger substance. I like bone marrow concentrate. I seem to get great results with bone marrow concentrate. It's more comfortable for me to use bone marrow than it is for me to do lipoaspirate from a re-injection standpoint. So unless the patient is really adamant that they prefer a lipoaspirate over a bone marrow aspirate to get their stem cells, I'm going to reach for bone marrow concentrate just because my outcomes have been so good. It's hard for me to switch.
You know, the way I make my decisions is usually severity. So it depends on how wide or how large this tear is. So the larger the tear, I'm going to go towards the bone marrow concentrate. Small tears or chronic tendonitis, and I'll stick with the PRP. The other thing we have, I always talk about, is that when we do our PRP, we kind of have a limited volume. So we can only, in order to get an appropriate concentration and dosing, we have to get a small volume. We take a large sample of blood, but in order for it to be effective, we're only getting a few milliliters of treatment solution in the end. Whereas bone marrow, the smallest we can concentrate it down, it still provides us with a lot of volume with still excellent cell counts. So it kind of depends. If it's multiple tears, then we're going to try to go with the substance that I'm going to be able to treat all those things at once. If it's a one tiny tear, a small section, then we're going to stick with the PRP, a smaller dose, smaller volume.
Yeah, same. So let's say, for example, so more often than not, right, when we look at these shoulders, we see not just rotator cuff tear. A lot of times it's rotator cuff tear and so. So a lot of times, like, the labrum is also involved, right? So what are you guys' thoughts on treating the labrum?
Labrum, I would always recommend the bone marrow concentrate. I usually, that's what I would say.
Yeah, if the labrum's the primary target and not the afterthought, I agree. I always go for the bone marrow concentrate. There are cases where it's a slight degenerative labrum on the MRI. A physical exam doesn't really correlate with the main pain source being labral pain source. So yeah, let's fix your main pain source, which is your rotator cuff, and with a little of the extra PRP, we'll throw it in the labrum as well and try to heal that up while we're doing the procedure. But if the primary target is a labral tear, I agree. Stem cells is the way to go.
Yeah, likewise. I guess we all practice the same way. So the same thing too. When the labrum is a target, stem cells For that one, I like using bone marrow like you guys do, but I also started incorporating lipoaspirin on there too, just from that theoretical matrix that it can form in there, especially when we're injecting into the glenohumeral joint, just kind of creating another cushion. It's one of these things that's theoretical. I don't think anyone's really looked at it. It'd be really cool to kind of see.
Yeah, and I can say at the IOF they asked that question, and there is no definitive answer at this point yet between bone marrow construct or lipoaspirin.
It was pretty much equivalent. It wasn't necessarily a better product. It was sort of what you felt comfortable with.
Yep.
So.
And then our last indication we haven't really touched base on is kind of the biggest grab bag term of them all, osteoarthritis. But someone who comes to us and they've been told they've seen the shoulder surgeon and a scope is not an option. I think I need I've been told I need a total shoulder replacement. Those are patients that we see often, and I would be the first to say not everybody's a good candidate, but some of them are good candidates for a regenerative procedure. And I guess in an osteoarthritis picture, John, I don't know if you want to go first. What's your approach to that patient?
Yeah, so for somebody with advanced osteoarthritis, I usually would always recommend stem cells for there. A lot of times I would gravitate more towards the bone marrow stem cells to treat it, because with osteoarthritis, you probably do have some labrum issues. You probably also have some rotator cuff issues too. The other nice reason why I like using bone marrow is that if it is advanced osteoarthritis in the glenohumeral joint, then we can do an intraosseous technique where we can inject the stem cells directly into the humeral head, just below the surface of that cartilage border of the bone. And it has that advantage of being able to deliver more healthier stem cells directly on the cartilage itself.
And some of the issue too is that we've talked about this with each other and surgeons, and a lot of times, unfortunately, when people get really advanced osteoarthritis on a humeral joint, they have a frozen shoulder. So they sort of lose function because everything around it gets tight. And even with surgery, even with the replacement, that doesn't necessarily come back. So trying to replace the joint doesn't necessarily improve the range of motion. It would help with the pain. And so if that's the goal, then definitely the stem cell treatment would be more practical than to have a major operation with no guarantee in the end. So it's just the facts.
Yeah, so we see those patients certainly on a weekly basis, if not a daily basis, and are very comfortable giving advice on what's worth trying first before going forward with a major reconstructive surgery.
Yeah, a lot of times too, like when patients come through here, we give them the treatment options that we have. I've had patients who came through, you guys have too, where surgery really is not an option, whether because of their advanced stage or some comorbidities as well. That even though we know that the arthritis is advanced, the tears are pretty big, but if it's a matter of just getting pain control and kind of reducing some of those symptoms, and surgery is not an option, then usually this will be the best option for them.
Another common question I'll get, and we should probably include today, is rehab post regenerative procedure. What's my downtime going to be? And that's a big contrast to the surgical options. So it depends somewhat on what procedure is done, but on a general basis, people are going to want to take at least 2 weeks off of doing aggressive activities with their arms, but they don't need to be in slings. They don't need to be immobilized. In fact, we encourage range of motion activities to prevent those frozen shoulders that Dr. Farhad had alluded to. And then the strengthening type exercises start shortly after that 2-week window, usually around the 1 month post-procedure mark, such that you're gaining strength, and we'll have significant improvements in that by the 3-month mark.
Yeah. A lot of times, like when patients come through, they have a chronic shoulder condition already. So a lot of the things that we try and do is correct some of those biomechanics that's been created all this time for compensation because of the shoulder issue. So part of the rehab is true. So with the orthobiologic, we're treating the structural issue. With the rehab, you're trying to treat the biomechanics around it. We should probably go through some questions.
Yeah.
We're kind of getting that set up. Maybe we can probably show you. So one of the things that we're really proud of here at the Michigan Center for Regenerative Medicine is that we've been contributors to Data Biologics. And what that is, it's a data registry where we ask our patients to voluntarily submit surveys to see how they respond to the treatments that we do. So it's a very transparent way of really seeing how our outcomes are. They were given the survey at the beginning of their procedure, so we won't know how patients are going to respond, but it's a good way for them to see. So this is kind of what we've had so far, and we're very proud of what we'll share with you.
So this is an overall view of three main outcome benchmarks, and satisfaction score is very important to us. Patients are 92% satisfied with their procedures. When you look at positive outcomes, there's a minimal clinical improvement threshold, and 71% of the time our patients are hitting that responder rate threshold. So we're getting a great response rate, and I don't want to say the most important, but certainly one of the things about a regenerative procedure is what's the downside, what's the risk. We can see that there have been zero, not a single one, major adverse event from a procedure. So there are some pain people have, which is anticipated, and 3, 5, maybe up to 7 days after the procedure, you might have some increased pain, but it's no major complications, not a single infection or nerve damage or any kind of a chronic worsening of the intended condition, which I'd probably be very confident in saying surgery can't report that. Can't report that kind of an outcome.
And then you can definitely see this is 1,500 shoulders we treated. So we've done a lot of these, and we've been successful in a whole lot of them. Yeah.
Oh. I think with that, we'll start answering some questions with the time we have remaining here. Sorry in advance if we don't get to your question. We had a bunch of them come through.
So question is from Ron Draper. Can you do both at once, or is it usually one side at a time?
Depends. Yeah. Rotator cuffs definitely can do both. Biceps tendon definitely can do both. If you're treating an osteoarthritic shoulder, chances are to completely treat one, we're not going to have enough cells to adequately treat both sides at the same time.
So Halter is asking, he's had steroid injections to his shoulders already. He gets temporary relief. He doesn't want to get surgery, and he's wondering if he's a candidate for a stem cell treatment. And yes, Halter, stem cell, when we talk about bone marrow cells and lipoaspirate, these are your quote-unquote stem cell treatments.
So the good news is if you've had response to an injection, a corticosteroid injection, then typically you will have a good outcome with orthobiologic treatments. Because if that structure that's causing your pain is injected with steroids and anesthetic and you get results, then that confirms what the source of your pain is, and then we go ahead and treat it with our biologic treatment and hopefully heal you. So the fact you get short-term results is a really good sign that you're a candidate for this treatment.
Great point.
Yep. And then as far as stem cells, we talked about the two sources of stem cells that we use, bone marrow stem cells and lipoaspirate. And Jennifer was asking, what are the sources of our stem cells? So we use autologous stem cells. So these are stem cells coming from you, the patient. We don't use the allogenic sources, which is from someone else, such as the umbilical cord cells and Morton's jelly and stuff like that. Let's see. We talked about recovery. All right, I think that's what we have.
And comments on that the allogenic sources of stem cells, it's a big question we get, and I really wish we would have, ability to use those cells in the United States, but the cells, we can't. Those can't be injected in the United States. Not because I think they're better, because I'd like to see if they're better. And so we're trying to get our colleagues outside the United States that are using those cells to use a similar registry so we can do direct comparisons. But the limited data we have that compares those definitely doesn't show them to be superior and likely to be inferior to allogenic products. So from what we can tell from the data that we have right now, what we're doing here at Michigan Center of Regenerative Medicine is the absolute best that you can get anywhere in the world.
All right. Well, it's about the time we have for tonight. Thank you guys for all tuning in and participating. Hopefully, you got a lot of good information from our talk this evening. If you would like to set up an appointment with any one of us, you can call the number here. It's 248-216-1008. We can do telemedicine consultations. We're here in Rochester Hills, Michigan. But we can also see patients over in East Lansing and Grand Rapids soon.
That's right. All right. Thanks, everyone. Have a great night.